is our managed care program that includes physical health benefits as long as long-term services and supports. We are being watched nationally because we are rolling out a managed care program for long-term services and supports, and we are one of many states that has done so. Each one of the individuals that's eligible for community health choices are individuals that are 21 years of age and older and eligible for Medicare and Medicaid or dually eligible participants. Also eligible are folks that are 21 years of age and older and receiving some sort of long-term services and supports, whether that is happening in a nursing facility or happening in a home and community-based setting. We do have individuals that are currently enrolled in the LIFE program. If participants are or folks are familiar with the LIFE program, the LIFE program individuals will not be enrolled in CHC unless they choose to be. And those folks that are eligible for CHC, if they're eligible for the LIFE program, they could choose LIFE as an alternative to community health choices. Folks that are not part of CHC, community health choices, are people that are receiving long-term services and supports through our OBRA waiver and not nursing facility clinically eligible. So the purposes of moving forward, nursing facility clinically eligible, we refer to as NFCE, and participants that are nursing facility ineligible, we refer to as NFI. So folks that are NFI, receiving services through our OBRA waiver, are not part of the transition to community health choices. Also, folks that are currently being served through our Office of Developmental Programs, or ODP. We are a family of acronyms around here. Those folks are still going to receive their services through the Office of Developmental Programs and will not be transitioned into community health choices. Also, residents in state-operated nursing facilities or veterans-operated homes will not be transitioned to community health choices. So here's our population as a whole. I can tell you the numbers have gone up a little bit, but probably a few thousand at this point. Statewide, there will be 420,000 participants that will be transitioned into Community Health Choices program. 94% of these participants are dual eligible. So I refer to them as our bring your own PCP group. So Medicare is primary, and they more than likely have a Medicare PCP, therefore they will be using community health choices for cost sharing and coverage of Medicaid covered services, non-Medicare covered services. So very key, and I'm going to say this many, many times throughout the presentation, community health choices does not change Medicare. It does not change the Medicare coverage at all. And also to note, a participant, if they have a Medicare PCP, does not have to change their Medicare PCP. They can keep their PCP as they move into community health choices. Something also interesting about this population, we have over 64% of the population are what we call healthy duals. So these participants are not receiving waiver types of services, or they are not nursing facility clinically eligible. Across the state, we have approximately 20% of our NFCE population, long-term services and supports population, that are receiving services currently in a nursing facility, and 16% are receiving that in a home and community-based setting. So you'll see as we move into the other overview of the next zone that we're rolling into, some differences up here across the zone. So here's our Southeast population. Sherry had indicated that we are rolling into the Southeast now. So we did successfully implement our Southwest implementation January 1 of 2018. We transitioned approximately 79,000 participants. And we are now full-blown into implementation of the Southeast zone of the state. This will include, this number's up a couple thousand, so this is approximately 129,000 participants that will be transitioning in the Southeast portion of the state. This group, specifically in the Southeast, we have a little bit lower percentage of dual eligibles, which means we have participants that are not dual eligibles but receiving home and community-based services or services in a nursing facility. So you can see the change in this population. We have more participants, 33%, that are receiving their services in a home and community-based setting, and only 11% in receiving those services in nursing facilities. The percentage also is a little bit lower for our dual eligible or our healthy dual population. They're at 56%. Something I also want to point out for this population, specifically in the Southeast, as we're moving into this zone, we realize that there's a greater number of these dual eligibles are receiving their services through a fee-for-service Medicare model instead of a managed care Medicare model. So they don't have a Med Advantage plan or a Med Advantage D-SNP plan like we saw in the Southwest. We only have 38% fee-for-service Medicare in the Southwest. So it's something interesting that we're seeing in the Southeast, that over half of our dual eligibles are still using a traditional fee-for-service Medicare model. And for us as the department and you as providers, that's important so that people understand that they're using a managed care model. They may need more assistance or information about understanding how the program might work. So here's our breakdown in the Southeast by county. You can see the lion's share is Philadelphia County, with Montgomery and Delaware, then following Bucks and Chester. So how does Community Health Choices work? I think that the majority of the folks on the phone are familiar with the seasoned Health Choices program. That's the managed care program that just includes the physical health benefits. So a reminder, Community Health Choices includes physical health benefits and long-term services and supports benefits for those people who are clinically eligible. So, this program works the same way. Participants have to choose their managed care organization. And when they do make their choice, they need to consider the provider networks and any additional services that we may call value-add services by those managed care organizations that may be more meaningful to them. Some may have additional vision or dental benefits. Some may offer additional transportation or transition services, nursing home transition services. So each one of those value-add services may have a different value to different individuals. The Department of Human Services then pays a per member per month rate, also called a capitated rate, to the managed care organizations. And of course, we, just as the Health Choices program, have a robust monitoring structure to hold the MCOs accountable for our quality outcomes and efficiency and effectiveness. If anyone is interested, the Community Health Choices agreement is on our website so that you can see what the requirements are for each one of our managed care organizations. And then, of course, the MCO is tasked with and obligated by our agreement to coordinate and manage physical health services, long-term services, and supports for participants, and work with Medicare and behavioral health MCOs to ensure that they are appropriately coordinating care, as well as developing a robust network of providers, and I will touch on some of that network adequacy in a little bit. So the goals of our Community Health Choices program are to enhance opportunities for community-based living. If someone wants to live in the community, they can live in the community, and it's our responsibility to try and ensure that they receive the services that they need to be able to safely live in a community-based setting. So that's goal number 1 for us. Goal number 2, strengthen coordination for LTSS services, long-term services and supports, and other types of healthcare. So that includes collaboration with Medicare and Medicaid services for dual eligibles, but also for the non-duals, it means coordinating with behavioral health services as well and community-based partners. So we are the program that is all about collaboration, and we have to be. We have 94% of our population that are dual eligibles, and Medicare is primary. So to enable us and the MCOs to ensure that we're appropriately managing the care for this population, we need to collaborate. We need to make sure that we're working with community partners, with our Medicare cohorts, our behavioral health partners, and our providers to make sure that participants are receiving the appropriate level of care and appropriate for that individual. Each one of our managed care organizations under Community Health Choices is required to have a companion DSNP. So a DSNP is a Med Advantage plan, so that's a Medicare line of business that is a special needs plan specifically for dual eligibles. So they are required to have a companion DSNP. A member does not have to choose that companion DSNP. They don't have to change their Medicare plan at all if they don't want to. They can keep their fee-for-service Medicare. It doesn't change their Medicare at all. But if they do choose to choose a Medicare line of business that's a companion DSNP, then our managed care organizations in the Community Health Choices program are better equipped to coordinate care. But they are still required to communicate with our dual eligible plans, our non-companion DSNPs. And we, the State Office of Long-Term Living in Department of Human Services, are also tasked with oversight of what we call the MIPA agreement. And the MIPA agreement is an agreement that we have with all 10 of our DSNP, Medicare, Med Advantage special needs plans in the state of Pennsylvania. And we've enhanced the language in that agreement to require them to exchange data and information with our health plans, with our Community Health Choices health plans in the event that a member does not have a companion DSNP. So their MIPA agreements have been enhanced, and our Community Health Choices agreement has been enhanced to require that everybody play nicely and exchange information for the betterment of our participants. Goal 3 is enhanced quality and accountability. So we started off the ground running with a robust quality plan. We actually gleaned so much knowledge and experience from our Health Choices program. It is, Health Choices has taken decades to season and grow into what they are today with value-based purchasing agreements and enhanced quality measures and requirements. So Community Health Choices benefited from that, and we've taken a lot of knowledge from our Health Choices partners and established quality measures at the beginning. So we have performance improvement plan requirements, we have hefty quality measures, and we do adhere to the HEDIS quality standards. There are quite a few measures that already started with the program, and we're making sure that we developed oversight at the beginning. So we could do subsequent sessions for folks if there's interest about our measures, and so that providers will understand what we're tasking of the MCOs, because that's always helpful, to know why a managed care organization is measuring you in a certain way. Well, it's probably because we're requiring that of them. So that's something that we could do in the future for you. Advanced program innovation, goal number 4. As part of our Health Choices agreement, or Community Health Choices agreement, we require the managed care organizations to use innovative ways to meet the needs of our participants. There are social determinants of health that a managed care organization needs to tap into community resources to try and meet the needs of our participants. And that means we do require that a managed care organization has a housing coordinator. They also must work with participants and their participant service coordinators to ensure that there's employment opportunities if they wish to work, enhance employment training for the individuals. So that means tapping into community resources for items that may not be a covered benefit. We also, finally, our goal 5 is increasing efficiency and effectiveness. And if we've done the first 4 well, then we know we're going to be seeing efficiency and effectiveness throughout the program. In order to measure that, we do have a lot of reporting mechanisms in place. We have operations reports, quality utilization and management reports, and launch indicators that we use at the beginning of each zone implementation to make sure that we're closely monitoring efficiency and effectiveness. So a comparison of fee-for-service and managed care. Of course, on the fee-for-service side, providers need to enroll in Medicaid as Medicaid providers. In the managed care side, that is also true, but I do want to point out that as a Medicare PCP that would be submitting for cost sharing to a managed care organization, they do not need to be part of that CHC network to receive payment for cost sharing up to the fee schedule, and I do have that detailed in the slide later on because I know that they'll be interested in that. Providers contract with the Commonwealth on the fee-for-service side. Yes, we still do revalidation. We enroll you, we do the revalidation. But on the managed care side, the managed care organizations are tasked with doing a credentialing process, and they follow NCQA guidelines for credentialing of providers. Part of that credentialing process is that they must have a medical assistance ID. So you start with us, and then the MCOs can credential you as one of their network providers. On the fee-for-service side, of course, providers bill the promise system. And on the managed care side, the providers bill the managed care organizations, and each one of the managed care organizations has their own unique claims processing system. So covered services, this is a big one because we've had lots of communication breakdown with the Southwest about providers thinking that Community Health Choices was just for long-term services and supports, or Community Health Choices was a Medicare product. No, that in fact that is not true. So think of Health Choices plus. So we are physical health services plus long-term services and supports for folks that are nursing facility clinically eligible. We also coordinate those behavioral health services that are covered by the CHC or the behavioral health managed care organizations. So all participants have the adult benefit package that's the same package as they receive today. That includes the physical health services of physician services, specialist services, and again, Medicare coverage does not change. All participants will have behavioral health services. Those behavioral health services are provided through the behavioral health managed care organizations. Those behavioral health managed care organizations are the same as they are statewide. They are by county. So they're the same behavioral health organizations that you've been working with already. This is new for some of our participants. So some of our participants that were in the aging waiver and folks that were residing in the nursing facility were receiving services, behavioral health services, through the fee-for-service delivery system. Once they get converted into Community Health Choices, they'll be receiving services through the behavioral health managed care program, MCOs, and they will receive additional benefits that they did not receive in the past. So on this slide, you will see some of the services that are available to them. And I do know that there's been a lot of outreach, and specifically in the Southeast, the counties have been getting involved in targeting education to nursing facilities and participants that are eligible for services through the behavioral health managed care organization, so that they know what services will be available to them and how to access them. So transportation services. All CHC participants, Community Health Choices participants, have access to emergency and non-emergency medical transportation. So just as through the Health Choices program, participants will continue to use the Medical Assistance Transportation Program, MATP, for non-emergency medical transportation to and from medical appointments. Participants residing in nursing facilities are the exception, in that nursing facilities have traditionally in the past arranged for that transportation. They can still do that. Each one of the managed care organizations has a transportation broker. So providers can work with that transportation broker to arrange for transportation. They will work with nursing facilities to help coordinate transportation as needed. An additional benefit for this population, nursing facility clinically eligible participants, those folks that are eligible for the waiver types of services, also have access to non-medical transportation. So non-medical transportation includes transportation to, church, if they want to go to community activities, if they need transportation to employment or volunteer activities. This transportation benefit must be part of the person-centered service plan for that individual. They will work with their service coordinator to ensure that transportation services are included in their service plan. And they could include tickets or tokens for public transportation as well. That service is not a replacement for medical transportation, and it's not, it's only offered as an additional benefit for those participants that are nursing facility clinically eligible, and it's part of their service plan. So participants that qualify for long-term services and support, nursing facility clinically eligible participants, they can receive home and community-based services and supports that include personal assistance services, so services in the home to help with, bathing, dressing, light housekeeping, those types of services. Home modifications, vehicle modifications, personal response services, and a new benefit under Community Health Choices is pest eradication. We're very happy to include this service. It was communicated as a huge need, and it is a social determinant of health. So if, in fact, you do become aware of a participant that is in need of pest eradication services, please bring that to the attention of the managed care organization. They do have folks at the plan that are responsible for helping to coordinate those types of services for our long-term services and supports eligible participants. And if they're in a rental, that means that that's where that housing coordinator comes in again to make sure that those services can be coordinated with the landlord or whatever is needed for those remediation services. Folks that are in a nursing facility, the long-term services and supports in a nursing facility would be under this bucket of covered services. And participant-directed services. So participants that are the common law employer, they're employing their own direct care worker, that falls under this bucket of covered services, and those services will continue today. The only difference with under the Community Health Choices program is that the managed care organizations are coordinating the payroll to go to the financial management services vendor to pay the direct care workers. So continuity of care. For physical health services, it's 60 days, just as it is for the Health Choices program. But as we transition into Community Health Choices, we do have an extended continuity of care period of 180 days following a zone implementation for all long-term services and supports. So that means that managed care organizations are required to contract with all willing and qualified existing long-term services and supports Medicaid providers for 180 days after CHC implementation. That means participants can keep their providers, their long-term services and supports providers for a 180-day continuity of care period after that zone implementation. Nursing facility residents can stay where they are as long as they need that level of care unless they choose to move. And the Commonwealth, we DHS, are closely monitoring the MCO network adequacy to make sure that they have provider networks that enable choice for our participants for any needed services. So identifying the needs. I think under the Health Choices program, Physical Health Choices program, folks are familiar with the case management areas of the managed care organizations. That's for your chronic disease and behavioral health or cognitive requirements. Under CHC, as soon as implementation under the Community Health Choices program, a managed care organization is required to screen each new participant that are healthy duals within 90 days of the start date. That's a huge lift. They have to contact every member that starts with their plan within the first 90 days to make sure that there's no gaps in care and needs are appropriately screened, to make sure that they aren't missing necessary services or need to have a needs assessment. They must conduct a comprehensive needs assessment for every participant who's already nursing facility clinically eligible. And they have to conduct a comprehensive needs assessment for certain types of trigger events where the participant self-identifies a need. The CHC MCO themselves have identified a gap in care or a need, or the independent enrollment broker identifies that the participant has unmet needs or needs service coordination of some type. Also, they have to conduct an assessment if a trigger event occurs. So if they have an inpatient stay, the MCO must conduct an assessment at that time. After that, they must conduct a reassessment of at least every 12 months, unless a trigger event or one other of those events do occur. So the MCOs under the Community Health Choices program are not only responsible for the care management plan, so that's your chronic disease, cognitive and behavioral health needs, but also a person-centered service plan. So all of our long-term services and supports participants will have a person-centered service plan, and that plan includes both the care management and the long-term services plan. Person-centered service plan is developed through a planning team process, which includes the participant and any informal or formal supports that the participant wishes to include. Could include family members, their provider, their PCP, their service coordinator. The service coordinator is the hub of that person-centered planning process. So coordination with Medicare, I did touch on this before. It's essential that we coordinate with Medicare under this program. And again, Community Health Choices does not change Medicare, does not change the Medicare benefits. The participant does not have to change their Medicare plan if they do not choose to. But this program does promote coordination between Medicare and Medicaid, and it is focused on patient outcomes. So our dual eligible participants can continue to receive Medicare options as they do today. They could maintain having original fee-for-service model Medicare. They could choose a Medicare Advantage plan. They could choose one of the D-SNP plans. And that the CHC implementation does not change any of the services that are covered by Medicare. I did already share that each one of the MCOs are required to have a dual eligible special needs plan. And Medicare will still continue to be the primary payer for any service covered by Medicare. Providers continue to bill their Medicare of the participant for eligible services prior to billing Medicaid. And all Medicaid bills for participants will be should be submitted to the participant's Community Health Choices MCO, including bills that are submitted after Medicare has denied or paid part of the claim. So keep in mind that participants must have access to the Medicare services from a Medicare provider of his or her choice, and the CHC MCO is responsible to pay the Medicare coinsurance and deductible amount up to the fee schedule, whether or not that Medicare provider is included in the Community Health Choices Managed Care network. So I'm going to stop 1 second. We did receive a question. What happens if MATP transportation will not transport the patient because the specialist they need to see is in the next county? If this is a Medicaid covered service and it is a Medicaid provider, then the MAT transportation should assist with a cross-county transportation. You should follow up with that participant's managed care organization to work with the MATP provider. There's also MATP transportation contacts. Those are all the same. We also have an organization within the Office of Medical Assistance Program that has oversight for the MATP program, and that information is out on our website with the contacts from DHS who have oversight for that particular county. So if you want to send me the particulars for that individual and the situation, I can get that to the appropriate people for you to resolve the issue. Okay. Service coordination objectives. So if folks are familiar with service coordination is a service that's for our participants that are long-term services and supports, nursing facility, clinically eligible. Now folks that are in the nursing facility under Community Health Choices will also have a service coordinator. But service coordination, traditionally in our fee-for-service model, service coordinators were an enrolled provider. Service coordination now is becoming an administrative function of the managed care organization, just like care and case management. Every participant receiving long-term services and supports will choose a service coordinator. That service coordinator is responsible for coordinating across Medicare, long-term services and supports, physical health services, and behavioral health services. They are also the hub for accessing and locating community resources for covered or non-covered services, so social, housing, educational, and other support services and support. Each one of the service coordinators does facilitate that person-centered planning team. They are an administrative entity of the managed care organization, and the managed care organizations could be using service coordinator entities that are separate and apart entities that they've subcontracted with, or a participant could choose a service coordinator that's actually an employee of the managed care organization. Each of the participants does have that person-centered planning team, and it includes folks such as their doctors, service providers, and any natural support. So provider payments. How are providers paid and the provider rates paid? And I know that Mara is going to touch specifically for your group about the FQHC payment methodology. But you will note that the same requirements for FQHCs under the Health Choices program are the same for the Community Health Choices program. So the Community Health Choices MCOs are paid a per member per month capitation rate, and those rates were developed using historical fee-for-service data, and of course they were adjusted for the additional benefits that an MCO may be providing, as well as projections for growth, adjustment for managed care principles, and improvements of care coordination. Our 2019 rates have already been developed, and there was consideration taken with the fact that there will be an extended continuity of care period. Following the continuity of care period, the Community Health Choices MCOs will negotiate reimbursement rates with providers. So just like as in the Health Choices program, DHS does not get involved in that negotiation of rates between a provider and the MCO. However, we do have contractual requirements regarding, the contents of a provider agreement and the notification of changes in network and that type of thing. The CHC MCOs can also negotiate with providers to perform specialized services. And the Community Health Choices MCOs may have regional rate variations. And again, DHS does not get involved in negotiations. Now, if you have attempted to resolve any types of billing or issues with the managed care organization and you do not see that you're having any success with that, you can come back through the FQHC Association, and Sherry will make sure that we get that information and work with you and the managed care organization to try and resolve any issues that you may have. So I think we touched on how the rates your provider rates are determined. And again, we, MCOs and DHS, have agreed upon tools for high risk or high cost participants. So after January 1, 2019 in the Southeast, participants served under the Community Health Choices program, services would be billed to that managed care organization. Each one of the MCOs does have their own claims processing system, and the managed care organizations are required to go through training. So you are required to be trained. The MCOs are required to have a training plan. They are also required to allow you to have a testing period. So if you have not worked with managed care organizations in the Southeast, please do so. And if you haven't, please let Sherry know, and Sherry will work with us to make sure that we get the managed care organizations working with you to get that testing set up. I do also want to point out, although the electronic visit verification, or EVV, does not apply to FQHCs, there is a requirement for home health services that the department is working on through a federal requirement. So those types of arrangements are also being still developed based on those requirements from the federal government. that won't impact the FQHC billing process. And also, if you have not had an opportunity to have any type of contact with the managed care organization, you know, like I said, we'll make sure that we can get that started and up and running for you.
Are you mentioning later who the managed care organizations are?
I am.
Okay.
There's a slide with the contact information for them, and I'll leave it on there for a little. I also want to take the opportunity at this time to mention that if you have any questions, you can always send them to my attention as well, and at the end I'll give you my email address. So providers have the opportunity to participate in claims testing. Like I said, our managed care organizations are required to adjudicate 90% of clean claims within 30 days and 100% within 45 days. So that's a federal requirement. We monitor that very closely. So the CHC MCOs do determine the payment cycles, and we will monitor their monthly processing files to make sure that they are in compliance with those claims processing standards. We do assess sanctions and impose sanctions on the MCOs if they fail to make timely payment to providers. So Southwest implementation. I touched on this a little bit. We effectively transitioned 79,000 participants January 1, 2018 in the Southwest. We are now up to 81,000 participants in the Southwest with the growth. We had lots of lessons learned in the Southwest. So big one was do everything sooner. Absolutely everything sooner and more frequent. We needed to engage our stakeholders much sooner, and we did that with the Southeast. Enhanced communication materials and training regarding Medicare versus CHC. So we also worked with the Pennsylvania Medical Society and CMS because we had a lot of confusion for our Medicare docs who, remember, 94% of this population has a Medicare doc, and they didn't understand what Community Health Choices was. We also have a group of people that are currently being served under Health Choices that are transitioned to Community Health Choices. So in the Southwest, we had approximately 8,000 people that were going from a Health Choices plan to choose a Community Health Choices plan. And they're not the same plans. So that caused some confusion, and it did cause some confusion with docs. So I'll touch on that a little bit once we get to the MCO slide. But in the Southeast, we have 14,000 people that will be having to choose a Community Health Choices plan. So this go round, we enhanced our communication, and our Health Choices plans are going to be sending out a letter in the next 2 weeks to those participants that are transitioning to let them know. And we, the department, have actually drafted this letter. And that copy of that letter will be out on our website, as with all of our other materials. So we worked with CMS to develop a Q&A document that went out through the Pennsylvania Medical Society newsletter to touch on some commonly asked questions for physicians. And we enhanced our communication about the continuity of care period. We asked our managed care organizations to start provider training and outreach earlier and more often, especially the service coordinators. We did earlier OBRA reassessment. So everyone in the OBRA waiver, we did a reassessment to ensure that they weren't NFCE and eligible for Community Health Choices, and we are done for the Southeast. We had stragglers last year. we're focusing on doing earlier data cleanup in the HCSIS and SAM systems. So HCSIS and SAMs are two case management systems. One is for under 60 population, one's for our over 60 population. And the problem in the Southwest was that we didn't really effectively focus on cleaning up both systems, and they house case management notes. So we passed incomplete and inaccurate data over to our MCOs to set up the care plans. So for the first 2 months of our implementation in the Southwest, we had to work with the managed care organizations, work with service coordinators to fill the gaps in that data. So we're doing a much better job of right now of doing data cleanup to make sure that before we pass the information over to the managed care organizations that it's accurate and complete. We also did more earlier pre-transition notices to the participants. And any transportation issues, we've enhanced communication about transportation services. In some ways, for our long-term services and supports participants, they may have been receiving transportation services in a way that we really weren't aware. So we've actually learned more about how some transportation services were being provided to our long-term services and supports participants. And we have scheduled a transportation summit for transportation providers in the Southeast that will be occurring November 16th to make sure it's being hosted by SEPTA. So we're actually working with all of our transportation providers in the Southeast to make sure that we're all on the same page when we head into implementation. So here we are, Southeast. I did touch on how we're incorporating all of our lessons from the Southwest. We did enhance our participant communication. We've actually just completed conducting 72 outreach sessions for participants. We have received requests from some adult day centers and nursing facilities to come and do one dedicated sessions if they have Medicaid participants that will be transitioning to CHC. So we may be doing a few additional, but we did enhance all of our communication for the Southeast. The priorities for our implementation, of course, is no interruption in participant services, continue to provide those services, and no interruption in provider payment. We were very lucky, very fortunate with the Southwest that our provider community was very supportive during implementation. If they had any issues not being able to see authorizations and that kind of thing for the managed care organizations, they knew they were under that continuity of care period. They continued to provide those services. So we didn't have those interruptions of services while they were able to work out any payment or authorization issues with the managed care organizations. So we were very fortunate to have that collaboration and participation from our provider community. We, the department, of course, we have a rigorous readiness review process. We have, once we move into our implementation, we will have daily war room meetings every morning with each individual meetings with each MCO. We also have end the day with a daily meeting of all internal DHS staff to make sure that everybody's on the same page of any issues that we might be seeing. We're collecting weekly launch indicator reports. So those are reports about complaints, denials, claims processing, paid, denied, pending claims, any changes in service plans. And we are having weekly stakeholder meetings. So we have individual meetings with stakeholder groups, home health providers, nursing facility providers, AAA service coordinators, our consumer advocacy groups. We are still continuing to have them weekly, and we will be doing that continually through Southeast implementation. And the importance of that is this is a partnership. We work very closely with our stakeholders and providers. You're our boots on the ground, and you can tell us if there are individual cases that need our attention or any items that aren't going smoothly. We're also working very closely with the Department of Health to review and approve the MCO's networks. So they have oversight of ensuring that the MCOs are meeting the network adequacy required for their operating authority. So of course we have our readiness review process. We're checking all materials. I think we're about 90+% done with reviewing all policies and procedures at this point in time for the managed care organizations for the Southeast, so we're ahead. We have regular ongoing stakeholder communication that I'll touch on in a little bit. And of course, you know, we have a lot of coordination between our offices and enhanced training that we have built over the last year that's all on our website. So for network adequacy for the physical health side mirrors what's on the HealthChoices side. On a national level, any instances where a participant goes to the provider, it's based off of driving times for urban or rural settings. That is the same for community health choices. When it comes to long-term services and supports, there were no national network adequacy standards, even though many states have implemented an MLTSS program. Those states have had network adequacy of a choice of 2 providers for participants. We in Pennsylvania were not happy with that. And we worked with our consumer advocacy groups and Department of Health to establish our own network adequacy standard for long-term services and supports. So this is for instances where the provider goes to the participant, to their home. And we based that off of past claims utilization and translated that into full-time equivalents. So when the managed care organizations are entering into network adequacy agreements or network agreements with providers, they're asking them how many employees they have serving the community, and that's because of us. So we did have providers say, wait a minute, why are you asking this? Well, asking for this is, we've never been asked this before. Well, that's why. The department is now measuring network adequacy of the MCOs by their ability to meet these full-time equivalents needed to meet the needs of our participants based off of our past utilization. And we will be refreshing that on the go forward with the encounter data that we receive from our managed care organizations. So now we have states asking us how we're doing it, and we'll be happy to report on how that's going as we move forward. So here's our map. Phase 1 with Southwest, Phase 2 Southeast, and Phase 3 is going to be a bear for us. It's approximately 215,000 participants for Phase 3. It includes 3 zones: Northwest, Northeast, and Lehigh Cap, and we will be doing that in 3 waves, but during the 1-year time period. So we're implementing Phase 3 January 1, 2020. Here's your managed care organizations. AmeriHealth Caritas, Keystone First. So AmeriHealth Caritas is in the Southwest, and they operate as Keystone First in the Southeast. PA Health and Wellness, they are new to Pennsylvania. They are part of the Centene Corporation. And UPMC Community Health Choices. So those are our 3 managed care organizations. They will be serving all 5 zones. They are our Community Health Choices plans. So back to those participants that are transitioning from HealthChoices. In the Southeast, we do know that out of those 14,000 people that are participating with HealthChoices, about half of them are with Keystone First. They can stay, they can choose Keystone First, or they can choose another of one of the other two. We also do have a large percentage that are Health Partners participants. So that's the reason why we decided, okay, we want to send out some dedicated notices, have the HealthChoices plan send out notices so that they understand that they'll have to make a new choice. I think it's about 5,000 that are Health Partners. About 1,300 are United, and about 460 are Aetna for the Southeast. So we are doing not only our regular outreach, but some dedicated outreach to this communication, to this group of people. Okay, so communications. This is so exciting. We have the best website ever. We've done a lot of work on this website. I'm really proud of this because I did come from the HealthChoices side, and I know that, the program was pretty seasoned, and we didn't have all of these materials. We are setting the bar because we have loads of materials, and for the Southeast and the Phase 3, they really lucked out because they're going to benefit from all the communications that we've put together. So there's two sides to the website. There's the provider resources side, so that's for providers, and then there's I need or receive services for participants. And this is the provider side, so there's a question and answer document. So last year we entitled this Frequently Asked Questions, and it has over 800 questions, so we decided to take the frequently off because you can't have 800 frequently asked questions, but we did add a nice table of contents so you can search by subject matter. These are not one sentence responses either. They are comprehensive answers. So I do encourage people to check out that if you get questions. Then subscribe to CHC News. This is a listserv. So this is an email blast. So if you want news about Community HealthChoices, just go to that link and put your email address in, and then you'll be added to our communications list. Presentations, all of the presentations, including variations of this one, are out on our website. This is exciting. So these are our narrated training segments. It even gives you your time commitment. So if you're like me, you like that audio and visual. It even has fact checkers built in. And I've had some providers tell me that they used this during their employee meeting, and played it and they watched it together. So I encourage you to check them all out. But the overview is 30 minutes long. Guess what? You can't fast forward. I'm sorry, but we did that on purpose. Direct service providers, so that would be your physical health providers. That would be a good one for this group. Service coordinators and nursing facilities, so folks that are in nursing facilities and nursing facilities social workers, that would be a good one for them. This is the fact sheet, so we're putting out new fact sheets all the time. We just sent one. It's a 17-page fact sheet, so it's fact sheets, but it's on EVS, so the eligibility verification system that I know everyone so finally uses every time somebody presents for a service to check their eligibility. We actually did a 17-page fact sheet to let you know whether they will be eligible for CHC and whether they're eligible for waiver services. And it tells you what it looks like if they've moved from Community HealthChoices to, or from fee-for-service to Community HealthChoices. It also gives you a copy of the ID cards. So you'll know what the ID cards look like for the 3 MCOs. So if a participant chooses Keystone First for both their Med Advantage and their Medicare plan, they will have one card and both information will be on one card. If they choose two different ones, then there's a copy of what that single card will look like for Medicaid. So this is what they look like. They're really nicely done. We have a nice young man in our secretary's office that is really good with graphics. So all of these are posted out on the website so you can use them to educate participants as well. Now this is what the participant side looks like. And this is where you find all of the documents that participants receive. So you can have a copy of every single notice that we've sent out to participants. If they call you and they say, hey, I received this letter, you can go out and look and see what it looks like. So this is what we've done so far. We sent out awareness flyers in July to all of those 129,000 participants in the Southeast saying, this is what we've done, this is what's coming, and this is what you're going to have to do. And then we had Aging Well events. Aging Well is an organization that hosted those 72 participant sessions that just ended. They started in August and they ran through last week. And there was invitations that were sent out to participants about those sessions. Then the department sent out pre-transition notices to that group of participants saying, hey, you're going to be transitioned to Community Health Choices, and soon you're going to receive an enrollment packet. Then the enrollment packet started going out from the independent enrollment broker. So now those pre-transition notices are going in phases, so there'll be multiple notices, and the enrollment packets go out after each phase. So participants will be told that they have until November 13th to make an MCO selection. But if they don't, of course, one's going to be auto-assigned to them, but they have until December 21st to change. So in essence, they can choose a plan up till December 21st for it to become effective January 1. If they choose after or decide, oh, I don't want to be with that plan, I want a different plan, and they make the choice after December 21, then their choice will become effective February 1. So they'll have to be with that plan for the first month. Service coordinators and nursing facilities. We have done training for them. Service coordinators have been fully trained. There's been probably over 700 service coordinators have participated in the training and have done outreach to over 6,000 participants in the Southeast at this point, the meaningful contact and talking to them about community health choices. So between the registrants for the participant sessions and our service coordinator outreach to our long-term services and supports participants, we've touched over 10,000 participants at this point for the Southeast. Nursing facilities are also outreaching to their residents and letting them know how to make a choice. Our participants, they are being told that they need to make a choice. So if a participant asks, yep, you have to choose an MCO, one of those three. This is the enrollment broker website for Community Health Choices. We have Third Thursday webinars. So these are public webinars. The information is on our website. Anyone and everyone can call in to these Third Thursday webinars to learn more about Community Health Choices. We've also hosted guest speakers. So last time we had our traumatic brain injury providers talk about how to do assessments for that type of groups of participants. You know, any interest for subjects that you would like to see, please feel free to send that to us and we'll be glad to include that in our Third Thursday webinars. We have stakeholder engagements, we have public meetings. We're continually doing outreach such as this one, so any ideas, additional sessions you would like to see, please let us know. Again, you know, talk to your MCOs about contracting and developing those provider agreements. Participate in our sessions and our Third Thursday webinars. You know, read and share within your organization any information that we receive. We will share additional updates through Sherry if you have interest about a particular area. Any of those additional educational sessions that you want to see us do, we can gladly do that for you. Here's our resource information. So the listserv information, you go to this website and sign up for the listserv. There again is our website. We have many public meetings that are subcommittees of the MAC meeting. We have a Managed Care Long-Term Services and Support sub-MAC. That's open to anyone, and they are public meetings, and we have past information and materials out on our website. They are transcribed, so you'll be able to read that as well. Any additional questions you can send to our RA email box. We've also listed our OLTL provider line and participant line, and the independent enrollment broker. So if folks need to make a choice of their managed care organization, they should make the choice through the independent enrollment broker. The phone number and website is there. So with that, we did
really a marathon.
Yeah, we did receive another question, so we'll wait for Mara to go over that question. So